Are we on ready? Great. All right. Well, welcome everyone. Very excited to welcome everyone here to our first semi-in-person grand rounds. We have a sparse crowd in the room with lots of masks on, but it's better than a bunch of people in their own rooms and offices on a purely Zoom call. So we are really excited today to have, again, our return to a quasi-in-person grand rounds, and also to have a outstanding visiting professor with us today. For CME color today, in honor, I'm going to do it, T. Duke Blue is going to be the color for CME today. In honor of T and our visiting professor. I'm going to invite Dr. Mormon up to give her formal introduction. And again, welcome to everybody. It's really exciting to have all this happening again today.
Thanks, Josh. I know that was hard for you. But as you all know, we've been looking forward to this day for a long time. We've got one of my favorite people on the planet and one of the real superstars in sports medicine, and particularly in women's sports medicine in the U.S. to be with us today. Karen Sutton comes from, like all the great ones, Duke from undergrad. And Karen was actually an All-American lacrosse player at Duke. And even more impressive to me is that she was captain of her team for 3 years. So if you can imagine what it meant to be captain of a national team as a sophomore, that really means a lot. She did her medical school at Maryland. That's where we got to be close and had the chance to get her involved in some of our research and the things that we were working on at Maryland. I knew at the time that she was a superstar and was really excited to follow her career. She went on to Yale for residency, and then after Yale, she did 2 fellowships. And one of these was at Harvard for sports medicine, which was a year-long fellowship. And then she spent 8 months on a pediatric sports medicine fellowship with Ben Coker and the team there. Got to know Peter Waters during that time, who you've also heard us talking a lot about more recently. Karen started out on faculty at Yale, and she was there for 7 years, and then has been more recently recruited to HSS. She's the head of the women's sports medicine program there, and was the lead on sports medicine at Yale as well before that. As Dr. Sabison will say, she's a member of all the appropriate societies. She's a member of ANA, AAOS, AOSSM, ASES. She's been a committee member or a board member on just about all those societies. And just recently, in the past couple months, was named to the board of our academy. So Karen is somebody that you'll really be hearing about. Karen also has quite a media presence. For those of you that have surfed social media, she's on the ESPN board for women's sports. And she's all over the place when you look up and see all the different things that she's done. She's got 45 peer-reviewed publications. She's an associate professor now at HSS, and is a real national leader in women's sports medicine. Most important thing that she's done is that she was the president of the Bassett Society. Who knows what the Bassett Society is? Come on, it's the amoebas. Athletes, medical opportunities endowed by athletes. This was a group of former Duke lettermen and letterwomen that started a foundation that provides scholarship support for Duke athletes. So Karen has been a leader in that and a big contributor to that as well. Karen is a real national leader in women's sports medicine. She's set the standards. She's going to talk to us today about a really important topic that I think we all deal with, and that is sort of the confidence differences between men and women, particularly in surgical skills. And she's very candid about that and talks about it, and has a lot of great insights in it that have been tremendously helpful to the people that she's mentored. And so we couldn't be more fortunate than to have Karen here with us today to talk to us about that. Karen.
Thank you, T. Thank you to Atrium Health and Ortho Carolinas for having me down here. It's always great to get into the North Carolina scene again. It brings back a lot of great memories, and certainly you'll see a couple of pictures of T throughout this, but there's not really a day that goes by that I'm not grateful to him for being into orthopedic surgery and being an orthopedic surgeon and a leader in my field currently. He has both been certainly a friend, a mentor, a sponsor to me. And I can talk to you guys a little bit later about what the difference is between a mentorship and sponsor, but he's really put me in a lot of positions where I maybe felt like I couldn't really, make the standard, but he encouraged me to go for it and really set pretty high goals. And I think that's the true definition of a leader. And I bring a little bit of that in today, talking about confidence differences in female versus male surgeons. One of the things that I noticed when I was going through my residency is after we'd get back to the residency room, which was a total disaster, as it should be, just, food everywhere and everybody's exhausted. It probably smelled a little bit from all the old scrubs. But I would notice we would talk about femur fractures, as we did actually last night. And I learned a little bit about rat femurs and the fractures and setting rat femurs, which was really impressive. But you'd come back and talk about your femur fractures, and the guys would come in and they were like, yeah, I did the whole case from A to Z. I did the whole femur fracture. I put the rod in. It took 2 seconds. It was great. It was awesome. And then I'd reflect back on my case. I'm like, well, I don't think it took me 2 seconds, maybe 30 seconds. I still crushed it. It was okay. But I would start getting in my head and think, well, I did notice that the attending did the reduction. So they kind of held the mallet in place as I was putting the guide pin down. I don't think I was able, there were a couple different tweaks that the attending surgeon made when I did my interlocks. And I just started reflecting. I'm like, wow, maybe they did a much better job than I did. And I never really talked about it because those are things that you just keep to yourself. And, you definitely walk in and put the Wonder Woman pose on, whatever you have to do. But as I got to my mid-career, which is scary, I'll still pretend like I'm a junior attending, but as I'm getting into my mid-career, I can talk to more female surgeons about, did they ever experience that? Did they ever feel like as they were going through their surgical training that they were maybe a little bit less confident than some of their male counterparts? And they did feel like that was the case. And so I wanted to delve into that a little bit deeper. The other thing that T was talking about as well is I work with ESPN, and I have the privilege every year to go to this ESPN Women in Sports Summit, where it talks about leaders in the field of sports. There are professional athletes there, there are CEOs of various companies, and you're able to hobnob with some really impressive people. And one of them was Danica Patrick. And I was talking to her after she did a talk, and I said, you're pretty impressive. You're out there in a male-dominated world. I also feel, I'm in a male-dominated field too. And I said, do you have any confidence issues when you get out and start a race? Or do you feel like, the men are kind of beating their chest? And do you have any challenges with that? And what she said, you know what, Karen, it's all about preparedness. She said, women just feel like they need to be a little bit more prepared in different situations. You can tackle everything, but you need to have just a couple of extra pieces of preparedness. So she said for her, she would prepare what she would describe as more aggressively than her male colleagues before races. She knew every turn, she knew all the competitors and what they were going through. So she felt like she tackled it based on preparedness, but she felt the same way. And she had to do a few different things with regards to that. Why is this important? Everybody brings up, oh, there aren't many women in orthopedics. Who cares? Why is that an important topic? First of all, I think when I did meet with a few of the residents yesterday, and I think it's really important to bring your diversity to the table. I think as you're starting out in the field of orthopedics, certainly as a fourth-year medical student getting into your PGY1, PGY2, you do have to follow the rules, play by the rules, and you're kind of under the guise of a lot of other mentors, your attendings, the senior residents. But I think as you start to develop who you are in your career, whether you're taking care of rat femurs, whether you're taking care of the Carolina Panthers, bring who you are to that aspect of your career, and it makes a big difference. So having a diversity within our field makes our field stronger. Orthopedics is a heavily male-dominated field. 14% of residents and 6% of American Academy of Orthopedic Surgeon active fellows are female. Result of many factors include comfort and confidence. I sit at many of these panels where we talk about having more women in orthopedics, and some of the concerns about it are, can I have a family amidst orthopedics? Do I have to be the Incredible Hulk to be able to reduce these fractures and instrument everything? I don't feel comfortable with a drill. I haven't used a drill before. But I think the intellectual aspect of orthopedics is now getting talked about more. And I think that brute force that's required, I think is certainly, You do have to have the strength to do it, but I think there's so many other factors involved in the field of orthopedics, and there are ways that we are bringing that message to the table. And I think a lot of you guys too, who are posting on social media, even though it seems very simple, people do see that message. Younger girls going into sports see that message, medical students see that message. So getting it out there, and the male surgeons really encouraging the female surgeons and talking about cases, it's really important too. And then certainly mentors, such as T was for me, really putting people in positions where they can shine is critical. Surgical educators are role models for medical school students and surgical trainees. Educator treatment of trainees can affect both trainee and observing students. And just going into some of these papers, there are a lot of papers in continuing medical education, surgical education, where they talk about how the differences in training for male versus female surgeons can be emphasized. And really talking about cases, we do this a lot in trauma cases where you go in and you do your preparation before the case. We used to have to draw out everything, write our preoperative plan, stick it on the side. Our trauma surgeon would walk in and, if you didn't get a really scrunchy face, then you did a good job, but he would always walk by your plan and kind of take a look. And, you didn't know where you stood either way, but you start doing the case and he's like, all right, see, that plan worked out. And you're like, yes, that's great. But really trying to work on those preoperative plans. And two, as you go from your career as PGY 5 going into your fellowship, and then as a junior attending, it's all the little things that matter. So start taking notes on a lot of those little things, the positioning, the instrumentation that you have there, and pay attention to those little things that make the case flow. Significant bias against female residents with regards to operative anatomy. They did a study in thoracic surgery where a lot of the attendings let the male surgeons do a lot more than the female surgeons. And at the end, when you look at that paper, the female surgeon was not as aggressive at kind of saying, yes, I do want to do part of that case. There was a little bit of a hesitation. So the take home from that was just saying, jump into those parts of the case, and certainly the attending's there to help you out, but really start making yourself feel a little bit uncomfortable in those situations while your mentor is teaching you as well. But it does create a call to action to address patterns of systemic gender bias within the surgical community. Advantages of increased diversity in orthopedics. Organizational excellence is greater with more diversity. There's actually not a lot of research on this in our literature, so I like to step out of that zone of just the surgical medical literature and start looking into more of the business side aspect for females in business, as well as in sports, coaching female athletes. I think it has a lot of similarities too. Companies with 3+ women in senior management functions score more highly on average in organizational criterion than companies with no women at the top, and also had a better financial performance relative to companies that had average standards of diversity. And this just doesn't apply to women, of course. Diversity in general really brings about new ideas. It can make an organization stronger. It can question just the status quo if your company's been doing the same thing for decades upon decades, bringing in new thought processes, diversity from the financial perspective, from the human resources perspective. It's really critical to get the company moving forward. Improved patient satisfaction. Patients of female physicians had more participatory visits in the study below, and more healthcare provider options to treat a larger base of patients. Sometimes patients in general, they want to come to doctors, various types of doctors, and it's not specifically a female patient wants to see a female surgeon, but I think just having the diversity of different people, different types of listening, different types of treatment. And again, it's just personality specific, where you get a diverse group of surgeons, a diverse group of physicians, and it's very helpful for the patients to come in and they feel like they can relate to their surgeon that they've picked and they've decided to pursue treatment with. A greater variety of experiences, background, thoughts leads to advancement in the field. One thing I found interesting just talking to the residents, and we went through and introduced ourselves, and just hearing the diverse experiences that you guys brought to the table. It was really cool, all of your various backgrounds, how you got to the field of orthopedics. It's pretty cool. And then I think you can always learn from one another. I think some of the residents were even surprised to hear, what the extracurricular activities were that the others did. But it really makes a program strong, and really kudos to you guys for having such a diverse group of residents. And I think that just makes the program even better as the time goes on. Impact of biases on women in orthopedics. There are cultural and character factors likely impacting female medical students' decisions on the career path. Some of the things that are obstacles for these women going into the field of orthopedics are lack of role models, implicit biases, inequitable treatment, discouraging females and other students from pursuing orthopedics. So just looking at who your leaders are, and the leaders don't necessarily have to be women. When I'm on these committees where we nominate somebody for increasing diversity in the field of orthopedics, these are people like, T, who has boosted me to the top, and then my fellowship director, who has really always put me in some amazing roles in the committees. And it just doesn't have to be your similar type of person that's leading you in that direction, but it's somebody who has an open mind and who really has the emotional intelligence to see where you're going to shine in your field. So the more time you spend with your mentors, even with your colleagues, understanding your roles, it's almost nice too in business, a lot of times they'll do a 360-degree review of yourself, where you're reviewed by, the equivalent for us would be reviewed by your scrub techs, reviewed by the CEO of the company, reviewed by your program director, and start to get some feedback of what you do really well and what you do poorly, and be able to take that criticism. I think that's really helpful as you boost yourself in your career, because sometimes you'd be surprised what your strengths are in appearance versus what your weaknesses are. So really try to keep those lines of communication open, and don't be scared of what people are going to tell you. There's pushback, discrimination, gender bias towards women away from the field, reported findings of orthopedic surgeons saying they felt women are incapable of operating, believed women should be purposefully pressurized into leaving surgery. So I always take that as a challenge. I was telling T as we were walking in there, and I think it's important to have a go-getter attitude when it comes to things. If somebody says I can't do something, I'll definitely come up with a way to figure out how you do it. And I remember I had a few situations where in residency, there was one attending surgeon who probably 10 years back wrote a letter to he was our chairman at the time. And he said there should be no more women in orthopedics. The whole letter was outlining why there shouldn't be women in orthopedics. We shouldn't have any residents anymore in female residents in orthopedics. And he was kind of notorious for, you got a little bit nervous going into his rotation. And in my rotation with him was coming up. And so I talked to one of the women who preceded me in the rotation, and she's like, oh, you're going to be fine. She's like, just, be who you are and do things that you feel comfortable with. It was a joint replacement surgeon. And so I went in, and this was pre my talk with Danica Patrick, which it would have been nice to talk to her beforehand. She could be my hype person. But it was before talking to her. And so I felt like, what's one thing I could do that I can affect change? You can't affect how other people work or how they see you, but you can affect yourself and what you can do. And I felt preparing. I thought, let me just figure out, I would talk to his PA beforehand, get a really good sense of what these cases were, try to delve into looking at the x-rays. He used all different components all the time, so you never knew the system that you were using. So I tried to think about what system we were using, talk to the reps, and do aggressive preparation for the whole rotation. And there was one time when I was taking out, I was taking out the femoral head and putting the corkscrew in. And you would basically, throughout that rotation, you would do different parts of the case throughout the day. So by the end of the day, you felt like you pretty much did a full case. And so he said, I bet you can't take this femoral head out in, 2 minutes. And I'm like, okay. But he's staring me down. He's looking at me, and, I have my instruments there. And I'm like, okay, wait, this is not fair. I was like, you go to the foot of the table, give me your 2 minutes, and I promise I will take this femoral head out, but don't stare me down. And so he was like, okay. And went down to the foot of the table. So I put this corkscrew in, and the anesthesiologist was a woman too. And she's like, so she was ready to cheer me on too. And so I was like, I felt I had the world on my shoulders, and all of a sudden you hear that, suction cup sound, and it comes out, and I was like, I did it. And but I was calm, cool, and collect, of course. And so he walked over and he's like, okay then. And then after that, he actually ended up writing one of my letters of recommendation for fellowship. He said I did a fantastic job on the service. And so he wrote a letter to Mass General, where Mass General had never had a woman sports fellow. And part of the reason why they hired me was because another surgeon up at Mass General was he wasn't too enthusiastic about having a woman fellow up there. But when he heard that this surgeon wrote the letter for me, kind of endorsing me for this fellowship, it opened his mind a little bit. And then, so I was the first woman to do the fellowship at Mass General, which I can talk to you about some challenges with that too. But I think that really it's important for all of you guys to accept these challenges. But if you do accept them, make sure you're prepared beforehand, which helps a lot. And then redefining the image of orthopedics, the perceived notion that the field is a sexist specialty most suited for strong men. I really never felt that way going through medical school, doing research with T, presenting at the Bassett Society. I remember the first time you asked me to present at the Bassett Society, I think I was like sweaty and very nervous because I was a medical student and everybody felt like a very smart, intelligent attending there. But I think I just haven't felt those challenges in the field all throughout medical school, residency, and then fellowship was probably the first time that I had any challenges as a female surgeon. In fellowship, I did my fellowship up at Mass General, and when we got there, the fellowship director had talked to all the professional teams and said, this is what's going to happen. We're hiring the first woman fellow up at Mass General. We're really excited. She's played sports. She's not a groupie or a super fan. She's very professional. And the team, so it was the New England Revolution, the soccer team, the Patriots, the Red Sox, and the Bruins. And a lot of them made kind of a separate orthopedic training room from the locker room. A lot of them had just the combination of the locker room going into the training room, but they did start to develop some separation there and did a lot of preparation for me coming down to Mass General, up to Mass General. And so every team was great. And then one of the teams, I won't mention the name, but you'll probably be able to figure it out at the end of it. But I went down for preseason training, which was, in July, and started meeting the players, meeting the coach and the owner. And we did a lot of the preseason physicals. It was the biggest team of all of those teams. And so, just went through the motions and felt really comfortable. I covered a lot of that same sport when I was in residency as well. And after a couple of days, I was supposed to go to one of their preseason games. And one of my co-fellows, he came up to me and he said, "Hey, Karen, I don't think you're going to be going to that preseason game." I'm like, "Well, what? That's odd." And he's like, "Yeah, I don't think you're going to go to that preseason game." And I said, "That's okay. I'll go to the next one. No worries." And it gets further and further into it. And it turns out I wasn't able to work with the team because a couple of players noticed my appearance, and it got back to the coach, and the coach said, "I'm not allowed to step foot on the field or do anything with that team." So there are some challenges still in the field of orthopedics, and what full circle came around, and the same attending who was a little wary about bringing women into orthopedics, into the fellowship program up there, he reached out to me and he's like, "Look, I don't really like what's happening here. And so I want to take a step in." And he was the head team surgeon for the New England Revolution. And he said, "Why don't you be acting team orthopedic surgeon for the New England Revolution, be there at their practices. Obviously, I'm there to back you up with whatever you need, but let me give you that opportunity to take care of them." And for me, that was a much better opportunity to almost be the lead for the team rather than sit at the back of the bus with another team. And it was just a great opportunity. So you never know how things are going to work. And I think you could be down on yourself if you run into any boulders in your career, any walls in your career, but really take that as an opportunity. You can potentially swing a different direction. And those little things, they do make you stronger in life too. So I think, we still have to realize that the world isn't, unicorns and rainbows, despite what my daughter thinks. And so I'll roll with her in that direction. But I think kind of being aware of the other challenges that your colleagues may face, both currently in residency, but then in their career down the road, and always important to check in with people. Breaking through biases, understanding teaching and mentoring styles that can help increase female diversity. The small percentage of females in orthopedic surgery may be due to confidence differences between males and females, and confidence is impacted by a mentor's guidance throughout one's career. So after talking to some of my female colleagues at HSS, I decided that we should do a bit of research to see, is this even a thing, or are we making this up? Is this in our head? And I worked with our GME director, and we started putting together some research on looking into this. The purpose of the study was to identify whether confidence differences exist between male and female orthopedic surgery applicants in the context of completing manually based surgical education tasks. And what we looked at, and I'll describe this in further detail, but the medical students interviewing for our residency have to do some various tasks. One is to suture a pig's foot. And as you're suturing the pig's foot, little shapes come up on the computer and you have to tap when a yellow triangle comes up. So it's a multitasking. It's also looking at your dexterity in terms of suturing a pig's foot, and it has a few different components to it. The other kind of aside with this too, I wanted to do this study, one, because of my background being an orthopedic surgeon and those discussions about the femur fracture, and my attending was not getting coffee the whole time that I was doing the femur fracture, and always wondering why that was the case, which I did ask those attendings later. I'm like, did my guy colleagues, did they do the whole case? And they're like, no, don't worry. But the second was from playing sports. And I started looking into some of the research in the coaching female athletes versus male athletes component to see, is there any differences there too? And it turns out in general, so a lot of these times obviously are generalities, in general, when a male athlete, I'll just use the lacrosse analogy, but a male athlete steps foot on the field and a female athlete steps foot on the field, and they're about to do, one of the tests sometimes we do is a 300-meter shuttle run where you'll do 50 meters 6 times. And the male athlete will get up there and just say, yeah, I can crush this. I got this. I'm the best on the field. I'm going to get the best time. And it doesn't matter that he may not get the best time, but in his mind, he thinks like, I'm going to really rock this. And I have no worries about it. And then the female athlete starts getting in her head where she may be the fastest on the field, but maybe last week, Susie came up next to her and she was close in her race. So she's like, I'm a little worried about that. And then, maybe today I'm just not feeling as good as I am. And everybody looks a little bit less tired than I do. So it's just a lot more of a thought process, or maybe this turf field I'm not as fast on. So it's a lot of thinking. And at the end of some of those studies, it does appear that female athletes tend to respond to a bit more positive coaching to start, and a lot more understanding of what the task is at hand. Like, okay, this is a 300-meter shuttle run. We're going to do this 6 times. You probably should pace yourself in the beginning and then sprint at the end, but some sort of explanation. And then we're doing this because this is a great test for midfielders and seeing how you're going to do on the field. And there's a little bit more of explaining what the purpose of the test is, why you're doing it, versus then coaching the male colleagues, like just get out there and do it. And that positive feedback. So a lot of male athletes will respond to the negative feedback, like, oh, you can't do this. You were so slow last week. Like, screw that. I'm going to be out there. But the female athlete responds a little bit more to positive encouragement first. And then certainly any criticism can fall behind there. But just a lot of the timing of the explanations can be different. So it's kind of that twofold, bringing in the sports background as well as the orthopedic background. So at HSS, we looked at a total of 216 orthopedic surgery applicants' data reviewed retrospectively. That was from that specific time where they were suturing the pig's foot, and then you were also tapping on a scale in terms of what shapes you're seeing. So again, that suture dexterity as well as multitasking. One of the problems of the analysis too, obviously, is there were more males applying than females. So the power gets to be very challenging. You have to have a higher power because of that discrepancy between the two. Bimanual coordination was evaluated. Interviewees had 8 minutes to reproduce 4 suture styles on the pig's foot, and then tapping the pedal located under the table when specific shapes appeared while suturing. The correct pedal count and total pedal count were recorded. Attending surgeons scored the tasks. And they were asked to self-rate confidence in hand skills prior to and after assigned tasks. So to summarize, basically the applicant coming in had to write, okay, here's the task. How do you think you're going to do on it? And they grade themselves on that. And then they're graded by attending surgeon to see how they did, as well as you have just the objective data from when you're tapping and talking about the shapes. And then after it, they also graded themselves. How do you think you did on this task? And this was all, then we coordinated that with their overall kind of HSS score and how we ranked them in general too. Male and female applicants performed equally on bimanual tasks. The pedal counts and surgeon graded task scores were similar between both cohorts. There were some years actually statistically significant. The pedal count was statistically significant, leaning towards the direction of the female applicants, but then recently it's starting to equal out. On average, females scored themselves lower than males on both pre and post-surgical evaluation scores, trended towards statistical significance. So right now it's P.08, but we have another round that we're analyzing too. And that's most likely due to the limited female population of the study. But to summarize in general, the female applicants did tend to underrate themselves going into the task, as well as coming out of the task feeling like they didn't do as well. And that was, we equalized that to how they did on the task as well. So this wasn't just, oh, those were the bad, female applicants, they didn't do that well. So it kind of coordinated too with the scores that they were getting on their suturing of the pig's foot. And then interestingly, these were just other random facts that came out too, but private school education and higher step 1 scores conferred lower pretest confidence. We're not exactly sure why that is, but it was interesting. Female orthopedic surgery applicants show similar proficiencies to male counterparts. When you look at the end score, that average seemed to be the same. So they both did well on the task, but then that trend towards decreased confidence relative to males. Our data suggests females demonstrate differences in surgical confidence compared to males on same tasks, and similar findings in other studies showing lower confidence in female surgical trainees. There was another one in general surgery residents where they analyzed a survey of 4,000 US general surgery residents, and they also had the same outcome where they saw that lower level of confidence in their female surgical trainees. Men tended to overestimate their performance and women tended to underestimate their performance, as shown by a resident self-evaluation of laparoscopic simulation tests. The reference down there, that was in OBGYN as they were doing laparoscopic surgery, and the women tended to underestimate their performance in that as well. So we wanted to look more into the orthopedic world and see where we stood with that. Confidence is shown to be affected by operative experience and autonomy in the operating room. As I mentioned, one of the earlier studies too, when I was going through the talk, studies of vascular surgery training programs demonstrated female trainees are left alone less frequently and less often given the lead case. And that might be multifactorial. I don't think that's blamed specifically on the attending surgeon or the trainee, but I think there's probably a conversation that could be had beforehand in terms of preparing for your case. I always like the, debriefing after the cases, as well as some early preparation talks before the cases, just so everybody is on the same page. And then previous research has demonstrated female residents excel with signal detection skill tasks requiring identification of visual patterns. So they seem to be very visual learners in terms of looking at the shapes and understanding anatomy through more of the, the diagrams and pictures and layers. Compared to male controls, females also exhibited greater cautiousness in avoiding errors. So some of the challenges, I say this because, in some of the studies, the women were taking longer in the surgeries, but then there were also, it's a catch-22 where they exhibited greater cautiousness in avoiding errors and demonstrated reduced efficiency on visual motor tasks. So it just took them a little bit longer, but they thought about things a little bit more. And then that outcome of the USMLE step 1 score and private medical school training were associated with lower confidence scores, maybe the result of less hands-on experience in medical school. Sometimes some of the more, the Ivy League medical schools, I see it personally because I was at Yale and then I was at Maryland for medical school, may not get as much hands-on experience as some of the more state-run medical schools. And the man, the myth, the legend, T. So my mentor relationship has been great along the way. I've just been blessed with amazing people, even going through the challenges with taking care of that one sports team in Boston. I just felt like still I had the confidence and building blocks of a pyramid of a lot of different mentors in my life, and it can make a big difference in your career. And I'm sure all of you guys are blessed with some amazing mentors. And I heard the program here too, you guys do a lot of mentorship training, and it's a mentor run program, which is really nice. And you take that for granted, but then you'll look at other programs and you won't get that as much. And it does make a bit of a difference. You feel a little bit more alone in those cases. But one of my good friends, Mary Mulcahy, and others showed mentorship can improve diversity, retention, professional development, and orthopedics. And the Ruth Jackson Orthopaedics Society is one of the ones for female surgeons. But again, I think in general, this is not a female versus male thing. I think for everyone going into orthopedics, just having that mentor-mentee relationship can be very helpful. And then, as I mentioned earlier, there is a difference between mentorship and sponsorship. So a mentor is somebody who you can talk to, who can guide you in your career. A sponsor or sponsorship in your career is somebody who really puts you in those situations. So I started learning those definitions as well. And, Dr. Morin and others have put me in some of the committee positions that I've been in, with a good background, I feel like too, but as well as put me to look to do presentations that maybe I'm not fully comfortable with. So that's where a sponsor can come through too, is start to look at those opportunities as well. And there's a medical student outreach program, which is created by the Perry Initiative. We did this at Yale, and then we did this at HSS too, where you bring in first and second year medical students and show them orthopedics, as well as data suggesting that the program positively influences female medical students' decisions. And there was an increase in residency matches relative to the past years. Just that exposure, I think, to different people in medicine too. And the Perry Initiative also looks at some of the underserved populations too. So both a financial diversity as well as a race and sex-specific differences diversity. It's very helpful to expose all of these people to orthopedics, because sometimes even talking to you guys as residents, you're exposed later on in life to the field of orthopedics. And it might be, your fourth year in medical school, and all of a sudden you say, this is what I want to do. And it would have been nice to see it a little bit sooner. And just looking at those opportunities to see outreach and having even smaller exposure to orthopedics can build that interest in orthopedics as well. Looking, as I mentioned, I did delve a little bit into the business side of things. I think there are a lot of parallels into business as well as athletics in this topic. And Ernst & Young, along with ESPNW, studied and emphasized the need for role models and mentorship. They interviewed 22 female entrepreneurs and expressed the importance of athletic programs developing their confidence and resilience through relationships with coaches and teammates. Tia and I were talking about this yesterday, where I think no matter what it is, for me, it was athletics, but if you did something to the nth degree in your life, whether it was, playing the piano or just ballet, taking something to a very high degree where you had to suffer through challenges, you had to have people criticize you, be able to take that criticism, that you bring to be a very strong orthopedic resident. And I think also they noticed in the business world too, it really made for C-suite executives to have that background in really taking something to the nth degree. Executive positions tend to favor persons that develop professionalism through sport. Report on 400 female executives, 52% C-suite with former athletic career, done by Ernst & Young Women Athletes Business Network and ESPNW. And the high achieving women succeed with equitable guidance and mentorship. What that study showed was the businesswomen who played sports, especially both high school and college, tend to get to those higher positions. But I think the same is true for just, again, taking something to a very high level and having to suffer through some of those ups and downs of it. So I think with failure comes success. You have to be beaten down sometimes to get to the next level of where you are. And I think that helps in orthopedics as well. And of course, athletics, sports medicine, parallel teaching tactics in athletics, where athletics coaches recognize the advantage of using different coaching styles for male and female teams. Men and women react differently to upcoming important matches. Male athletes' self-confidence remained higher than female athletes before the match, And then female anxiety levels were significantly lower at 2 different points before the match. And so this is where the female athletes' anxiety levels significantly lower. That's when the coaches were starting to prepare themselves and telling them and giving them some of the tactics to get into the game. So once they understood the why behind everything, they tended to settle down their anxiety level. Female versus male athletes approach tasks and challenges differently. Looking at former men's lacrosse coach and current women's lacrosse coach reports men and women are motivated differently. Men focused on showing their ability to complete the task given, termed the macro approach, versus women focused on the reasoning behind each drill, termed the micro approach, which challenged him to fully develop strategies to win. So this is talking to these various coaches and how they looked at those 2 athletes. The takeaways: recruiting and mentoring trainees that are different from your own background drive financial and personal growth, and advancing orthopedics will rely upon bringing together people with different ways of thinking and experiences. These are the references, and these are my team. The one on the left side is probably the most demanding of everybody, but then I do take care of the U.S. women's lacrosse team, and was just out in Austria for 2 weeks in January, taking care of the ski team. And those are the 2 USA goalies. I like it because I look very svelte in that picture. But those are the 2 USA goalies from indoor. So when they play box lacrosse, they wear these crazy get-ups. So that just gives you a glimpse into our research on confidence in female surgeons. And I'm happy to leave this time to answer questions for you guys as well.
Excellent. That was awesome. And again, so fun to have everybody here in the same room. In order for people to hear who can't be here, just due to our size restrictions, I'm going to ask people who are here who want to ask any questions to use the microphone. Any comments or questions? T, do you want to start us off?
Well, Karen, thanks for that fantastic talk. And if you're serious about education, nothing's more fulfilling than seeing people that you've worked with make it. And congratulations, very proud of all you've accomplished. I would ask for our women in our program, specifics you might help us with in terms of guidance for them in the OR.
Mm-hmm.
Are there specific things? You mentioned the preparation, that's really important. Are there any other sort of keys that you came across in your development that were really helpful and fundamental to getting to where you are?
One thing that I do that you guys may do subconsciously is I take that time. I don't like to use the immediate surgical scrub, just the gel that you put on there. I like to go to the scrub sink, and that is my time. Especially as residents, you're pulled in so many different directions before you're scrubbed into cases. You need some sort of time to clear your mind and focus on that case at hand. And the scrub sink is kind of a very appropriate way. Nobody can really bother you. They have to stay a little bit away from you. And I take that time. My scrub sink has a window to both of my rooms that I'm running, and my reps, everybody knows not to talk to me during my time at the scrub sink, but it's 5 minutes where I can think about, are there any odd pieces of equipment that maybe we could have forgotten to request? It reminds me what the patient looks like and kind of gets a background of that patient. I see who's in the room. And also I'll go into this part, but you do have to be the captain of your ship in the operating room too. But when you're at the scrub sink, really take that time to be in the zone of surgery. I hear a lot of you guys with families and little babies, and it's just really a challenge. All of a sudden your child has an earache and somebody's calling you from that. But that should be your sacred time to really focus on getting into the case. So that would be the first thing I would say, is just take that time at the scrub sink to do your kind of surgical meditation. And I always have a mantra that I use, and do the best of what your hands are trained for. So we're not God. We can't kind of go in there and there's a blown up tibial plateau fracture and make it look pristine like the person was 16 years old, but you can do the best of what your hands and mind were trained to do. And that's the best you can do. So have some sort of mantra before you walk into the cases. If you are a little anxious about the cases, I think is really important. And the second thing I would say, this is getting more towards PGY5 fellowship and then your first years in training, is walk into the OR like you're the captain of the ship. You may be nervous, you may be challenged. I was approached at Yale to do some leadership training for some of our newer surgeons. because there were reports that the nurse didn't feel comfortable working with that surgeon because he or she had papers up all over the wall trying to remember their anatomy. And but you have to walk in there, make decisions, be decisive, rally the troops, make everybody feel really confident around you. I think music is really helpful for that. Just having a smile on your face, even a little thing, just walking into the room and say, this is going to be a great case. Meanwhile, in your mind, you're like, I don't know what is going to happen. This is going to be a nightmare case. Like, this is going to be terrible. But you could set the standard and say, this is going to be a great case. This is going to be a hard case. We're going to be in here longer. So everybody starts to have that mindset. They're not thinking it's going to be a 1 hour case, realize that it's going to be longer, and they can prepare for that. But that's your team, and you have to rally them. And again, they look to you, they look in your eyes, they see how you feel. So fake it till you make it and walk in like you're the captain of your ship. We're actually doing I'll do a plug for, we're doing an instructional course lecture this year at the Academy with Matt Provencher, Ashish Bedi, and Mary Mulcahy about leadership, both in the operating room as well as in your career. So for those of you who are at the Academy, you can check it out too. It should be fun.
Karen, I really enjoyed your talk. Thank you very much. I had a question both for the male and female residents in the room and on virtual. Most of the books and experiences on successful people, one of those traits is having just a little bit of insecurity and a little bit of fear of failure that motivates them to become successful. And there's tons of examples of that. How would you suggest to everybody in the room and everybody listening, and also reflective of your experience, how to balance just that motivational insecurity and motivational fear of failure versus being paralyzed by it? How have you dealt with that, and what have been your experiences with others?
One way I've dealt with that is through making decisions. When I was in residency, I think probably the residents that had more challenges were ones that were just in their head and they couldn't make decisions, especially if you're in a trauma case, you have to keep moving forward. So just like you're making that, you're preparing for that trauma case, you're putting together that preoperative plan, you have to make decisions. There are different ways to do these cases. And I think you could be concerned about the case, but you have to keep moving forward. So that I would say is one, is make a decision, stick with it. You can kind of accommodate if maybe it wasn't the perfect decision, but there's always ways that we can work around in orthopedics. And two, I spoke with one of my buddies as I was early on in my career at Yale. And I said, every ACL, I still get, my stomach hurts a little bit. And, I want to make sure everything goes smoothly. He's like, Karen, I'd be really scared if you didn't have that feeling and you just walked in like it was fine. So I think it's important because we care as physicians. This is the difference. My dad was a cardiologist and could not understand how I was convinced somehow to do orthopedics, which is construction work and just, putting in screws and nails. But we're not construction workers. There's a patient behind each of those cases, and having that concern, that's why we're in medicine. So it's an appropriate concern. It makes you a better surgeon to understand, each ACL I do, I feel like is custom for the patient, whichever graft I use, whichever hardware. And I think that concern brings into your treatment for the patients. So the two things I would say would just be make decisions, and two, it means you care as a surgeon.
Dr. Sutton, thank you for a fantastic talk. It's clear that we're losing talented females at the medical school level. I think over half of US medical students now are female.
Yes, that's correct.
And yet only 12% are going into orthopedics. So do you think that's the right time to intervene and expose these talented females in medical school to orthopedics? Should it be earlier? Should it be in college or high school? And who do you think should be doing that? Should this be an academy initiative, other organizations? And what do you think could be done further or more aggressively to push that needle?
So I had this conversation actually over the last year with the Academy. I'm on the diversity advisory board, and the Academy is always talking about, let's meet with the first year residents. Let's meet with the second year residents. I think that's great, but I, like you were hypothesizing too, thought, these first year medical students or second year medical students, I remember the first time I reached out to T was probably first year in medical school, where being a college athlete and getting into medical school, it was such a depressing time to just sit there and study kidney, nephrology and all this other stuff. I'm like, this is awful. Let me go for a run and try to do something. And that's when I think a couple of my buddies from Duke said, reach out to Dr. Mormon and maybe just to have lunch with him. And, he's such a great positive influence. So I think first year of medical school, having almost, it sounds cheesy, but like a career fair or some understanding of what this career entails. I think people don't realize, like, the field of orthopedics, the people in it are so amazing. And I don't think they see that until they get to that medical student 4 rotation going through it. So I think we should capitalize on who we are as a group of people. And it's such an incredible field, but I think they are exposed to it very late. And I think that they get concerned that they don't have the research behind it. And as we all know, obviously it's a challenge to get into orthopedics. So, we can't just say, oh, if we meet these people, yeah, do it. And then all of a sudden we see their USMLE scores and we're like, sorry, maybe don't do it. But I think, early in medical school would be opportunistic. College, a lot of schools will do some medical program in general. And I think just getting women into medical school, they're doing a really good job with that. So I think it's going to be the early medical school time that would be helpful. And, I started working with the academy. It's just tough because they focus a lot on their members and the members obviously aren't the medical students yet. So it's kind of, are we looking at the big global picture or are we looking at the individual picture?
So we're going to try something here. Dr. Gant is on Zoom and she's going to ask a question. Erica, do you want to try and ask a question?
Yeah, thank you, Dr. Sutton, for your talk. I did my residency at HSS, so I'm very familiar with the culture there. And I did a fellowship at Duke, so I've been in some of the places you've been in. Right. I guess, a great talk. Thank you for the overview. One thing I think it's important for the male surgeons to hear is that there are real gender differences in the way that we're socialized as children. And I think it's really critical to remember that, particularly in the operating room, there's a double bind for women because there's a double bind of authority associated with women. And so some of the hesitancy you see in the operating room is often the way that we've been socialized as children. It's okay for little boys to brag. It's okay for little boys to be the best in the club or the smartest kid in the class. The way girls are socialized, it's always about cooperation, getting along. You actually are encouraged not to be boastful, not to brag. That's the way girls are socialized. And so there's a double bind when you become a woman surgeon or woman executive or high-powered lawyer. And, kind of the example of that would be the Hillary Clinton type where you're perceived as the B word. And so I think we have to be careful on saying that the women residents have to prepare more than the male residents. I think actually the gatekeepers, i.e. the attendings, the residency directors, the fellowship directors, have to remember those tendencies are different in the beginning. So that confidence does not always equal competence. I mean, we've had tons of male residents that we could see thought they were pretty confident, but not always competent. And that sometimes, just like your study found, women are much more likely to grade themselves lower, but actually have the competence. Yeah. So that hesitancy in surgery really may be that the male surgeons, the female surgeons, all the gatekeepers need to recognize that if you're staring somebody down or giving them several minutes to get something done, women are much more likely to relent and say, okay, you take over the case. And the male residents are not going to do that as easily. So I think it's the gatekeepers that actually have to really work on understanding those differences between our women and male residents and making it an inclusive environment that recognizes those differences in the way that we're socialized as children.
I think that's a great point. And there is a really cool book who is a great author for anybody who has young children. It's Strong is the New Pretty. It's a photography book. It's not, you're not going to read it, but it's really cool. It shows young girls, like babies, even in kind of the opposite gender role that they are thought to do. And so they've showed the book to other girls and they're like, oh, wow, like that's so cool. She's kind of in the mud, like doing this stuff. And so there is, as she would talk about in her book, there is that implicit just bias as we're children. And yeah, we're taught to kind of sit, raise your hand, don't cause a ruckus. That's where I think sports was helpful because I caused a big ruckus on the sports field, which, trended to later on in life. But I think that's a good point. And I have talked to a lot of my really amazing leaders who are men in the field of orthopedics and asked them how they handled a lot of it. And it was just kind of in the operating room, understanding that they did talk a lot more to the female surgeons where they were explaining certain parts of the case. And again, part of it is, just the why behind everything. So I think it's important that not even, kind of male versus female gender biases, but just even backgrounds that people are coming from too, just understanding that and being aware of that in cases. And I think it just makes us a better society if we understand that too. It's that emotional intelligence, which is critical.
Thanks. Erica, thank you for asking that question and making those comments. And for everybody else who wants to know, we could hear you perfectly in here. So kudos to our tech team this morning. But it's interesting, and I'll be interested to see from your research study you're doing. Do you have it broken down at all to look at, I guess you have everybody's application, so you could look at what their experiences were, your data that you showed about women who had had a sports experience or some high level experience.
Right.
I wonder how that would play out if you use that as a variable across both sexes. And, I always wonder that in male applicants as well.
Mm-hmm.
People who have had some sort of high level, doesn't have to be a sport, but some, I loved the comment you made about somewhere where you have been in front of people, you have been subject to criticism, you've had to sort of accept that criticism and build from there. It's a very interesting concept to sort of think about that. And, I'll also give a shout out right now to our residents for participating in this, but Gabby O'Day, who is one of your fellows, she is leading a big study that I've been working on with her at a multi-center study. And I think Mary's involved with it, Dawn Laporte, lots of, I think we have about 15 programs around the country. We're actually looking at individual learning styles. So trying to see, is it a learning style thing? Are there different ways that we should coach or teach people to individualize it a little bit? So I think that there's a lot of potential for changing how we teach. And I think that's, really individualizing it.
Yeah, we're going back at the data because we do have all those applicants, and we did want to look at, I think it was hard to get the other activities that people have taken to that extreme level, but we are looking at athletes, irrespective of male versus female. And, there are a lot of different variables that we're kind of going back and looking into now that we've seen that there are some, close to statistical significance with the confidence.
Very interesting. Incredible talk today. T, any final words for us as we close things out?
Yeah, just want to make a small presentation to Dr. Sutton. Just a little bit of Charlotte to take back to New York with you. First of all, and thanks to Brian Middleton, who I think is still here with us, but here's a little swag for you from Atrium. And then on behalf, you see Jonathan Rebo and Pat Connor and Durham Weeks all here who take care of this team that you may have heard of, the Carolina Panthers. This wouldn't fit your goalies, but it'll fit you.
Thank you.
And the most recent addition we have to Charlotte is our new MLS team, the Charlotte Football Club. So we have, and Jonathan Rebo will be our team doc for them, and Durham Weeks will be supporting him as well. So on behalf of those guys, here's some Charlotte things to take back to New York for you.
Thank you so much.
And thank you so much for being with us. You want to move to the hot seat? Will the hot seat be here? Okay.
Take a couple second minute break while we set up.